school still?
Yeah. Bob Marley died in Illinois.
Yeah, relatively.
Yeah.
There's somebody also.
Are you seeing what I'm seeing?
What do you see? Oh! Good eyes.
Can't hear you. Hold on.
How was your weekend?
Thank you so much. Going on.
What? Do you have any self-care? No.
Hi.
Morning.
How are you?
Okay, we can start. So, first of all, how was your weekend? I hope all you are fresh, energetic, and we're going to start the new week, right? Okay. So, today's program is about the bullous disorders and the drug eruptions. And then I saw that on Friday you have already studied that subject, right? So, we are going to make a little change in the gear, and instead of I talk, you sleep, I sleep, you talk, right? So let's move on to something different, like this. Okay. Let's see where we are. Here we go. Okay. So first of all, what is this? Yuma, what is this? What do you see? How about this one?
Pemphigus vulgaris,
Right? It's like an erosion, right? Some part of the skin has
Not all
lost.
of them is erosion.
This is erosion, yes. This is erosion, and then you will see here again some crusting and erosion, and you will see some erosions in the oral mucosa, right? Okay. What could
Wouldn't erosion have more liquid to it?
it didn't rise? Because this is the dried liquid basically what you see, right? Okay. So what could be a diagnosis of such a case? Painful erosion is a middle-aged man, Jewish, and then painful erosion starts with the painful erosion in the mouth, and then after a couple of days, this develops these rashes on the skin.
Pemphigus vulgaris?
Pemphigus vulgaris, right? So whenever you see an erosion, you need to think that this erosion happens by something, right? So you are looking at a blistering disease when you see an erosion. Now, generally speaking, what are the mechanisms of blister formation in the skin? What are the mechanisms of blister formation in the skin? Yeah. How we can have a blister on the skin? I told you today I'm sleeping, you are talking. Okay. So how is the mechanism? What are the mechanisms of blister formation? How we can have a blister?
Has to do with the desmosomes in this case.
So one of these is, for example, you may have immunobullous, right? So you have antibodies against a component of the epidermis or basement membrane zone, and then they separated and become blister. What else? What can make a blister?
Friction? Like not
Trauma,
trauma?
right? Heat, burn, friction. You may have cause blister. You see blister, one is it could be a trauma, right? So you have your blister on your shoes, you can have a blister from the bear, right? Okay, what else? What else? Aria,
Medication. Medication.
same story.
Oh.
Okay, what else?
Infection.
Like, we have seen many of these. Which infection causes blister?
Staph or strep?
Staph. From the viruses?
Herpes?
Herpes, right? Okay, what else? What else?
Cancer?
So you have different component in the attachment between the epidermis and the dermis. There are several layers. So if you have any genetic mutation in any of those components, then you have this attachment loose, and then you can easily separate it from each other, right? So we call these groups mechanobullous. Contrary to the immunobullous that they are immunogenic, here you have some structural deficiency in some part of the proteins, and then you have a loose skin basically. By slight pressure, by slight friction, the epidermis and dermis separate from each other, they become bullous. Right? Anything else? So when you see a bullous disease, when you see erosion, you need to think, okay, what I'm looking at the bullous lesion. So then you have to categorize which kind of group it belongs to, right? Then according to that, you make your differential diagnosis. Okay, so do you know any medication that causes pemphigus? Any medicine can cause pemphigus? Can be medication mediated or not? Like? Not sulfa is not a very common. The very famous one is the penicillin. Penicillin, rifampin, captopril, these are the medications that can cause pemphigus. So what is the mechanism of blistering here?
The desmosomes have antibodies against them.
Okay. Which class of antibody?
IgG.
IgG, okay. And then what happens?
Complement comes and destroys the desmosomes.
What happens? In pemphigus, there is no complement. In pemphigus, the antibody attached to these desmosomal proteins and then separate them and they cause the cell to shrink. So So you can have, for this reason, you can have pemphigus lesion on the normal appearing skin, not red skin, because there is no inflammation. It could be inflammation secondary to that, but it can happen on the normal skin, right? Okay. So if you want to treat this patient, what will be the treatment?
Corticosteroids, immunosuppressants,
For what?
topical.
No. What are you going to treat? You have antibody, right? You have lots of antibody that attacking the cell. So you want to stop that antibody formation, right? So corticosteroid is an immunosuppressive that generally affects the immune system. It affects the cellular, the humoral, complement, everything, right? So if you want to specifically stop the antibody protection, what you're going to do?
An antibody for the IgG.
Or for the cells that produce IgG. Have you heard about CD20?
Yeah.
What is this CD20?
B cell marker.
B cell marker. So we have antibody against the CD20. It's called rituximab, right? So imagine in these cases, if you start to give him corticosteroid, that usually we do, right? So what happens here, for example, a regular regimen for this patient is 100 milligram prednisone per day plus 150 milligram azathioprine. This is the classic standard treatment for this kind of patient. So now you have a patient that does not have any skin barrier and immunosuppressed, right? So it's like a house that the door is broken and there's a red carpet asking the bacteria, all the pathogens to come inside, right? So for this reason, the mortality is very high, okay? 5-year survival or survival of disease. How is it? Is it a serious disease or is it not a serious disease? Okay? Previously, before treatment, the 5-year survival was even less than 20%. 80% will die. And remember that they are middle-aged people, right? So by the treatment round, it's much better right now, but still we are right now dealing with the complication of the immunosuppression that we're going to treat them.
The Fortuna, right, is an adult patient?
All of them adult. All of them adult, right? Okay. So that's it. Okay. So let's go move on. Yeah.
I was going to ask about the oral mucosa with the to get rid of those lesions, to use the topical rinse such as viscosis lidocaine.
These are helpful. These are supportive
Okay.
treatment, right? So you
Gotcha.
do some supportive treatment, basically
Okay.
over here, supportive treatment. Okay. So this was the Pemphigus vulgaris. Okay. What is this? What is this cell? What do you see? What do you see?
A lot of looks like macules and patches.
So from the from the left side, you will see some. By how you describe this? It's a plaque, basically, right? It's like a urticarial plaque. It says erythematus, edematus, no scaling, right? And then in the middle, you have this tense blister. When we say tense blister, it's like this, right? And over there, you have so much scratching. These are scratch marks, right? Because this patient has so much itching, so scratch it up. This is a sign of this severe itching. So this is an elderly person, right? And comes with the severe itching, and then this lesion. What will be the diagnosis? Bullous pemphigoid. Fantastic. Do you know any medication that causes bullous pemphigoid? Any medication that causes bullous pemphigoid? Any medication causes bullous pemphigoid?
Is that what it's at the sulfa?
1, 2, 3. Sulfa. That is one. And then, but the most common medication that causes this one is either the loop diuretics like furosemide, or for example, anti-diabetic from these DPP4 inhibitors, like a gliptin, saxagliptin, sitagliptin. These are the commonest. And you know that these people are old, so usually they have hypertension, they have diabetes, they are taking this kind of medication, and they come with this picture, right? Okay. So, what is the antigen here, and what is the antibody here? Antibody is IgG, and what is the antigen? What is the hemodesmosome inside? There is two antigen, 180, that is collagen type 17, and then 230, that is the plugin, right? They have two antigen. Any association with this bullous pemphigoid? Any systemic disease associated with this bullous pemphigoid? So again, this is elderly people, and then usually they have an association between neurological disease, like people have stroke, like dementia, or Parkinson, because we have collagen 17 in the CNS as well, right? For this reason, there is an association between these two. Okay? So, among these two diseases, bullous pemphigoid and pemphigus, which one is commoner? Which one you most probably see in your life? This one.
Because
Much
it's less,
commoner,
it's less severe.
right? The pemphigus, most probably, if you are not in becoming dermatologist, you won't see, but usually you will see that.
Because it's less severe.
It's more commoner. It's more commoner. It's more commoner. Okay. So, again, here on the pemphigus, is that the typical picture is that patient comes with a painful oral lesions, right? And then later on, the skin rash appears. Here, usually people come with this very itchy rash. This is the first presentation. This is here because we have the complement activation, and this blister happens as a result of the inflammation. So you have this eosinophilic spongiosis, means the infiltration of the eosinophil into the skin, and then they are very itchy. Sometimes this stage lasts a long time, so you won't see the blister immediately. So this is a diagnostic dilemma. You have to do the biopsy to find out, yeah, this is the bullous pemphigoid without the blister. Do we have any mucosal lesion, oral lesion in the pemphigoid?
No.
Is it common or not?
No.
It's not. It's not a common. Okay? Okay. How are you going to treat this? How we are going to treat that one?
Immunosuppressant.
Immunosuppressant. Again, same story. We have a lot of antibodies, so in severe cases, you can go for that anti-CD20, right? And then sometimes it will be very limited. You can have some topicals as well. One more thing. Look at the distribution. So on the pemphigus, always we see pictures on the head and neck. It's on the upper part of the body. On the pemphigoid, usually is in the lower part, right? The common thing is on the lower part, most probably, but it can spread to the everywhere.
So in the bullous, it's on the neck.
In the pemphigus, here here mostly on the leg, lower abdomen, right? These are the things that can help you. Okay. So, bullous pemphigoid.
Yeah.
So what you see here, you. Excuse me, what you see here?
Like on the left picture, like a patch,
Uh-huh.
and then on the.
What is this again? What is this? What is this? Again, you see some sort of erosion, right? Again, when you see erosion, you need to think about the blistering disease. But you will see some, even like a scaly patch, crusted patch, right? And again, you will see mostly on the upper part of the body, face, chest, back, sometimes the scalp, right? So what is the diagnosis here? So if I say you it is a family of the pemphigus, which kind of pemphigus is this? The superficial one, the pemphigus foliaceous, because you don't see that blister you see in the first picture, right? So I bring it back to you. See this one, and then you see this one. We talk about this medication that can cause pemphigus. Most of the medication in this pemphigus belong to this pemphigus foliaceous. They can be easily on the face mistaken for eczema if you don't pay careful attention to the course and also to these little bit erosive papules and patches that you will see on the upper trunk. So what is the antigen here? Desmobilin 1 or 3? So let's pull. 1 or 3? Ma'am, 1 or 3? 1 or 3? 1 or 3?
Basement's still good. Oh, that's how you taught it.
Maybe I made a mistake. Maybe. Because this is 1. So this I said 1, 2, 3, right? 1 from the top, 2 or 3. Maybe I made a mistake. 1, 2, 3. So it goes like that.
Oh,
It
yeah.
goes
You
like
said-
that.
you
It goes
said
like that.
3,
See?
2, 1.
See, it's like that. If you see 1, 2, 3, it goes like that. So you don't have basically 2, you have 1 and 3. So in Pemphigus vulgaris, you have usually antibody against both 1 and 3, you have skin and mucous membrane. If you have antibody only against desmobilin 3, you will have only mucous membrane. You don't have any skin lesion, right? Okay. So thanks God, we find that one. Okay. So Pemphigus foliaceus. What do you see here?
Either papules or erosions of vesicles.
Don't answer politically. Don't make a room for yourself. Look at carefully and see what is this.
Okay, on the left side I see papules, and on the right side I see.
What is called excoriation. It's a scratch mark. Somebody has scratched, right? Excoriation. So where is the location? This is the elbow.
The elbow and the butt.
This is
cheek.
the buttocks.
Yeah.
So it will be flexor or it will be extensor.
One thing we have right
Okay, I just.
This should be a boundary.
Okay.
All right.
Okay.
Extensors.
So it's an extensor. So flexor, elbow, buttock, knees are extensor, right? So it's an extensor. So, and then how is the arrangement of the lesion? Are they separated or they are grouped? Grouped. So you have again a young man with the very itchy, grouped papules on the extensor. Okay. What's the diagnosis?
Inverse psoriasis.
We are in the field of the Bullous disease disorders. What will be the diagnosis? This is dermatitis herpetiformis. So what is the disease systemic association with this dermatitis herpetiformis? Systemic association with the dermatitis herpetiformis. Come on, guys.
Celiac disease?
Celiac disease, fabulous. And what is the cause of celiac disease? Autoimmune disease for
Gluten.
gluten, fabulous, gluten. So when the gluten goes, there is a part called biliary. You get sensitized to that and you develop antibodies against the tissue transglutaminase in the gut, and they cross-react with the skin tissue enzyme and cause this kind of rashes. Which antibody is involved here?
IgA.
IgA, fabulous, right? And then what will be treatment here?
Mostly immune suppressant. Dapsone.
Fabulous. Anytime you have IgA, you have neutrophils, the treatment is dapsone. Anywhere you see IgA, you will have the cells that involve are neutrophils, the treatment is dapsone. One of the characteristics of this dermatitis herpetiformis is that it gets worse with some sort of chemicals, especially iodine-containing chemicals, right? Like a potassium iodine. So previously, even without biopsy, if you give some people, when the person comes like this, if you give potassium iodine, itching gets worse. And this is a not a steroid responsive disease. No matter how much cortisone you throw at it, it won't get response. Okay? Dermatitis herpetiformis. Don't forget that. So let's see. What is this?
Oh,
So what is the most common immunobullous in children?
Steven Johnson?
Most common immunobullous in children. It's called linear IgA dermatosis. Here, the thing is that the picture is very characteristic because of this annular configuration of the vesicle and bulla. It's called a string of pearls, right? And usually affect the lower part of the body. Of course, you can see this linear IgA dermatosis in the adult as well. But most common form is in the children. Right? So just remember that that is the one thing. If any children with the blistering diseases, immunobullous, this will be the diagnosis. Okay. What is this? Now what you see here?
Plaque, erosion.
Okay? So first of all, this is a child, right?
Mhm.
They bring
Yeah.
a child food to you with some blistering where? On the knees, on the sole, the site of the friction, the site of the pressure, right? So now you have to think about mechanobullous, the diseases that has genetic mutation in some part of this element of the dermatodermal junction. Based on the location of the separation, we have many different type of the Epidermolysis bullosa. So let me So this is the basal keratinocyte. You have some filaments, and there are some structures here, and there are some structures here, and there are some structures here. So each of these structures can be mutated genetically. According to which structure is damaged, you will have cleavage on the inside the basal keratinocyte, or below that, or even on the upper part of the dermis. So based on this, we divided this epidermolysis bullosa to simplex, to junctional, to dystrophic, because when it comes to the lower upper part of the dermis, you will have a scar. So again, the commonest form is the epidermolysis bullosa simplex. That has mutation in keratin 5 and 14 and are part of this element inside the basal cell. So you will have kids bringing with this picture. They get easily blister on the friction area, and usually by the age they become better. They improve with age, right? But there are many forms of this epidermolysis bullosa that some nasty form, generalized form, dystrophic form can cause severe destruction of the tissue and skull. Okay. So, what is this? Sir, what is this?
Looks like
You know that, right?
wow. I don't even know how to start, where to start. It looks like there's some erosions in the picture on the right.
Okay.
This looks painful, like purpuric exanthum.
Uh-huh. And here,
Uh,
you will see some hemorrhagic crust on the lip. So this child has taken some sort of medications, and in 2 weeks it becomes like this. So what is this? The famous
Steven Johnson.
Steven Johnson. Fabulous. Okay. So let's talk a little bit about the drug eruptions. in general. What are the predisposing factors for developing drug eruptions? Who gets drug eruption more? Who gets drug eruption more frequent? Immunocompromised, yes. What else? What else? Female. You got more of this reaction. See, this is a girl, and the other one's a boy. What else? People who take many medications, they are on polypharmacy. A person who takes many different type of medication, the chance of getting reaction is more. If somebody has a previous history of drug eruptions, right, is again a clue that most probably they have a higher chance of developing drug reactions. And some underlying viral infection make people prone to develop drug reactions. Like what? Like what?
HIV?
That makes it prone to develop reaction to?
Diabetes.
HIV makes people developing reaction to?
Herpes?
Drug reaction. Drug reaction.
Penicillin.
So usually to sulfonamide, especially this cotrimoxazole that we give to them because of this prevention of the pneumocystis. What else? Disease, very classic disease that can cause increase the chance of the drug reaction. Super classic.
Syphilis?
Why would a child have syphilis?
Super classic. So if somebody has
Influenza?
infectious mononucleosis, and you give what? Ampicillin, and they develop a rash. I should bring it from deep of your mind out. Right?
That was there.
I should bring the deep of your mind out. This is the way I try. You are reading so many information. You have to organize them in your mind. Remember, please, there is no unnecessary information in the medicine. Whatever they teach you, whatever you're learning, has some benefit. You are not learning something that is useless. We don't have anything like that. So every information is important, either directly or in connection with the other. So you have to organize them in your mind, so you'll be able to pull them back, right? Okay. Yeah.
What about vaccinations?
Vaccination does not increase the chance of reaction to medication. Vaccination by itself can cause reaction, right? We are not talking about, for example, you have this infectious mono, and then if you give ampicillin, then you have a rash, right? This is so classic that sometimes, because the infectious mono usually comes with a cold, like a sore throat, and you give them ampicillin, and 3-4 days later they develop a rash, then you know that it's infectious mono. This is so characteristic, right? Okay. So now let's talk a little bit about the
Let's do some more.
Will do. So, who is more prone to develop this SGSM? Which age group?
Just say children.
Children, yeah, that's it. Yeah, young adult, right? How much is the mortality of this? How much is the mortality of this situation?
Oh, mortality.
Yes.
It's high. Mortality. is
Give me a
high.
number.
60%.
Oof.
30 to 10. 30.
Oof.
30%.
30, 60 is a death sentence, right? 30% is too high. So basically, in a very advanced expert facility and people who know that catch early is something around 5%. On average, is 20%, and in some place, maybe like here, it's around 50%.
But this looks like it's coming from underdeveloped countries with the outbreak.
It doesn't. Don't look at the pictures because they can be anywhere, right? But the gravity. I want to grasp the gravity of the situation. A young person, a child, take a painkiller, take an antibiotic, and dies because of that. Because you have to be able to recognize this situation. For this is they stress more and more and more because people die with this. Somebody's children have a sore throat, you give a pill of antibiotics and die because of simple drug reaction. This is a serious issue. How usually they start? How is the general picture? How they come to you? So the first symptom is some prodromal symptoms, right? Fever, malaise. So you have it, somebody comes with that, and then what happens next? You will have some mucosal lesion like conjunctivitis, and then you have the spread of the skin lesions, and then you have the extensive mucosal lesions on the aura. Again, remember, this hemorrhagic crust is very characteristic of SGS10. Which medication causes these kind of reactions? Medications?
Antibiotics.
Antibiotics. Usually we have a few class, these are nasty medicine. They are causing most of this reaction caused by this. One of these antibiotics. What else?
The NSAID.
NSAID. Okay.
I said anticonvulsants.
Anticonvulsant, anti-seizure medicine, right? What else? Allopurinol, fabulous. And antimetabolites. These are usually, most of these reactions, if you look at the cause, it will be sitting one of those medications because these are. And remember that antibiotics, NSAID are really commonly used, right? So these are the cause of this. Okay. So that is the SGS10. What is this?
It's contact dermatitis. Definition.
You are so quiet today. What is this?
It's like there's inflammation of the joint, and then second layer cutaneous.
What do you see? Define it for me. What is this? Define. Definition. You have an erythematus patch or maybe thin plaque with some central duskiness. See this central duskiness over here? And then sometimes this center becomes blistered, become vesicular, right? This is a typical case of fixed drug eruption. Fixed drug eruption is not rare. And then the main culprit here is the NSAID. And as it says, the name is self-explanatory. So each time you take the drug, you got the same reaction on the same place, again and again and again and again. Right? But each subsequent medication, it's taking the same medicine. You may develop some new ones, but definitely the old ones will come back again. So this is a case that I had recently. This is sent by a photo, a young lady, and said that during the past 10 years, I got these rashes on my finger, blistering, each time I get my monthly period.
Wow.
Each time I get my monthly period, I get these rashes over here. I have seen several doctors. They have been given some medication for the herpes because they think that's a herpes virus. Cortisone cream they give me, they become a little bit better. Again, next month, I got the same thing.
Is it because she's taking some sort of medication?
Fabulous. So you understand first. It takes half a second to understand that this is a fixed drug eruption. Then you have to go back in the history. Ma'am, what you are taking during monthly period? For the pain, I take painkiller. Then we dig up. Then we find out that sometimes she take one of them, the other take the other one. And then maybe half an hour chatting with this online up and down. Finally, she recognized that, yeah, this naproxen I take, I remember that the last time I take, it becomes immediately tingling. 10 years problem solved. Right? So this is a fixed drug eruption. Characteristic comes at the same place. Remember this color. This is a very characteristic color. And then when they heal a post-inflammatory pigmentation. You will see some dark patches. And you see how round it is. Very round or very round. Yes?
So for instance, if somebody were to take Tylenol that once a month, would that lead to a chronic issue?
No. But if you take it, if you get this reaction to any medication, each time you take, it will happen the same, right? People are sometimes very creative in telling stories. Again, the common places for this fixed drug eruption is on the hand, on the feet, on the lip, and on the genital, right? So imagine a couple comes and one of them develop this one. Then the drama starts, right? What happened? What you have done? And then another time I have a patient who was from a lady from India, and she said that whenever I travel to Europe, I got this cold sore. But whenever I travel to India, I travel anywhere else, I didn't get that one. Right? So strange. Because these are misguiding. You have to take correct information. So you look at this and you see that this is a fixed drug eruption. Okay, what happens when you go to Europe? I take a painkiller because I want to walk a lot and want to shop. So but when I go India home, I don't take any painkiller. So this is a little bit tricky. Okay. Fixed drug eruption. What is this? What is this? You describe it for me. You describe it for me. I try to summarize whatever I told you.
They're flat, not elevated?
Some of them flat, some of them elevated. So if you look at from the side, you will see some macules and papules that they coalesce in the center, they merge into each other, and they spread to the limbs. Okay, so what is the shape of this? Which kind of rashes we call this one? Definitely today I will jump out of this window, by sure, 100%. So it's called, it's called rubelliform. Okay, rubelliform, like a rubeola, like a measles, right? You have some macules and papules that start on the center, merge in the center, and spread to the side. So usually people come with this. They have two diagnoses basically. Either it could be viral, meaning of the viral disease, especially in children. They can the same picture, and in the adults, both viral and the rub. They can produce the same picture. So remember this picture. This is a rubelliform rash. Morbilliform rash. Morbilliform rash.
Oh, morbilliform.
Morbilliform.
Oh.
Morbilliform rash. Right? I'm human as well. I make a typo as well sometimes, right? Yeah. So this is a morbilliform rash. This is the most common type of the drug eruption. 90% of the drug eruption is morbilliform rash. So most probably you will see some morbilliform rash. Generally speaking, we divided drug reactions based on the intensity to mild, to moderate, and to severe. This is one of the mild form that does not have any systemic implication. It's only on the skin.
Could you tell that it's pruritic just by
Yes, yeah, it's pruritic. And then you have moderate that have skin and some systemic involvement, like a vasculitis, like a urticaria, and then we have severe, like what you said, Stevens-Johnson syndrome, right? That's the severe, life-threatening. Okay, so let's move on. How we diagnose drug reaction? Clinical picture, timeline. This timeline is super important. So don't think that somebody take a pill and comes to you and say, okay, I just taken this pill newly and then I got this one. People are on multiple medications. They take antihypertensive, they take for the diabetes, and they take painkiller, and they change the medication. So you will see a patient with 10 different medications taking at the same time, and you should find out what is the culprit, which one is responsible for this. So simply you will see here that urticaria and anaphylaxis usually affect very shortly, in a few hours. Then this one that we are going to talk about later on is again in the first few days. And this three, usually this exanthematus, like a morbilliform rash, happens between 4 to 10 days, usually around 7 days. The SGS-10 between 1 to 3 weeks, usually around the 2 weeks. And this dress syndrome after 3 weeks. Right? So you have to look at this, and then according to the history, you can say which medication is related to the reaction you are seeing. So, what do you see here? Ma'am, what do you see here? Say morbilliform rash, right? This is a morbilliform. This is a morbilliform. Same as the previous one. But with some other features. What do you see on the face? Swelling, fabulous. So anytime you see a morbilliform rash hit the swollen face, this is called drug-induced hypersensitivity syndrome. So in morbilliform rash, you don't have this swelling on the face. This reaction is a rare reaction, but it is very often questioned because we have some tricks on that.
What is it called again?
DIS or DISH, drug-induced hypersensitivity. So first of all, there is not much mucosal lesion. These people don't have any mucosal lesion. They usually have lymphadenopathy. They have internal organ involvement. Most important one is, most important or most common organ involved in this syndrome is liver, yes. It can affect the kidney as well. And one funny thing is that here, that this has a late onset. Usually it starts after 3 weeks. And even maybe you take the medicine for 1 week or 10 days, you stop the medication, and then later on it starts, right? It's not necessary to take. So you have to see this one, you go back and say, okay, what you have taken in the past 3 weeks. Any virus involved here?
But it can?
Any virus involved here? Any virus involved here?
I think not.
HIV.
Any virus involved here? Herpes, human herpes simplex type 6 and type 7. Reactivation is somehow involved. This is the same that in acute infection causes Roseola infantum, right? So in reactivation, it has some connection with this disease. Okay? People with this syndrome, they may got some thyroid or diabetes a couple of weeks later. So if you diagnose with this and treat that one, then after 2-3 months you have to check their thyroid because they may develop hypothyroidism later in the course of this. Just one point. These are, as I told you, this is not a common disease, but it has many points that usually often asked.
There's an actual destruction of the thyroid.
It's like the inflammation, yes, yeah, it affects the thyroid, yeah.
Reversible?
Yeah.
Just take away the drugs?
Some part reversible, some part maybe not. Because as long as the inflammation is there, definitely you will see the symptoms, but the inflammation is gone, you have to see how much damage is there. Okay, what is this? What do you see here?
So we got vesicles?
Is it vesicles or something else?
It looks.
What is this?
Pustules.
Pustules. You will have a sheet of pustules, and this is called acute generalized exanthematous pustulosis AJA. What other disease we talk that you will see sheets of pustules everywhere? In which disease? that comes in the differential of this. These are non-follicular, tiny pustules. You will see start on the flexors and all over. Psoriasis. Pustular psoriasis can have the same appearance, right? But here you will see there is a history of the medication, and as I told you, this usually starts very early. In first 1 day, 2 day, 3 day, immediately after the medication, you have this acute generalized exanthematous pustules. These are the main important severe drug reactions. Stevens Johnson, this one, previous one, these are the main serious. Okay. So what is this? Let's change it here. What do you see here?
Hives?
Fabulous. You see hives. But which kind of hives? Do you like an ordinary hives you have seen? This is a young man that says that I got very itchy and developed these rashes. Anytime I exercise, anytime I become embarrassed, anytime I take a hot shower, and you will see small hives, mostly on the body.
Urticaria?
Which kind of urticaria? This is cholinergic urticaria. This is again common things in young people. As I told you, each time they sweat for any reason that they sweat, they may develop these rashes.
So would we just know it's cholinergic urticaria just from the presentation? Or we
Because
have to do
here,
something?
because whenever you want to sweat, the sweat glands are innervated by the adrenergic, but the transmitter is acetylcholine.
I understand
And
that.
that acetylcholine causes mast cell degeneration.
But if somebody presents to you in your clinic and says every time I get a rash, how would you know?
History and the shape. Small, you know, this is the usual urticaria you have big plugs. This small one that comes immediately, they clearly said in less than 10-15 minutes of the sweating, it starts. Of course, they are not telling that clearly. They say after the shower, after the exercise, then you have to connect the dots, right? You find out, okay, anytime you sweat. And the simple thing that if you have stairs in your office, ask them to jump a little bit, go up and down, they sweat, and you immediately will see this one.
Okay.
This is a test. You can find out. So, this was a cholinergic urticaria. What is this?
Facial edema.
Angioedema.
Angioedema. Fabulous. Okay, what is angioedema?
Esterase inhibitor.
Sorry?
The C1 esterase inhibitor deficiency.
This is angioedema. So we have urticaria, that is edema on the upper dermis, and we have angioedema, that is edema in the deeper dermis and subcutaneous tissue. This is the definition of the angioedema, right? Angioedema can be histaminergic, related to the histamine release, or can be non-histaminergic. The histaminergic one usually may be accompanied by urticaria or anaphylaxis, right?
Yeah.
And the non-histaminergic is caused by what? What is the mediator here in non-histaminergic?
Bradykinin.
Bradykinin. Okay, fabulous. And then if you have genetic hit that one, this was genetic C1 esterase inhibitor, or you can have acquired C1 esterase inhibitor, right? Like what? Which diseases you have acquired C1 esterase inhibitor?
Herpes.
Lymphoproliferative disorders, lymphoma, this kind of family, you may have some acquired, okay? So the characteristic of this non-histaminergic angioedema is that they develop very slowly. It takes a couple of hours to appear. Creates slowly, and usually affects the face, the mucosa, the tongue,
anaphylaxis will occur much quicker?
Much faster. Okay, much faster. So anytime you see a urticarial reaction to a medication, among all these things we talked about up to now, if you see any urticarial reaction to any medication, what is the most important thing you need to consider? The possibility of anaphylaxis, because they have the same thing. But anaphylaxis can happen without any rash. It doesn't necessarily that you have urticaria or angioedema. You can have the anaphylaxis without any rash. But if you have seen this urticarial reaction, there is a chance that they progress to be anaphylaxis. Okay, so let's see here, angioedema. And this is, which medication causes this? ACE inhibitor. So you cheated here, sorry. That's okay. What is this?
Anthrax?
What is this? What you see here? What you see here? Necrosis, right? You will see necrosis, and you will see this bluish, reticulated, like net-like around that. Now if I tell you this medication has been on warfarin for the past 1 week or 10 days, what will be the diagnosis? Any idea?
Something.
Any idea taking warfarin? Warfarin. What is the warfarin does?
Blood thinner.
Anticoagulant. What is the mechanism of action of the warfarin? Fabulous, fantastic. So, which coagulating factor is related to the vitamin K? 2, 7, 9, 10. 2, 7, 9, 10 are the factors that are related to the vitamin K. And we have other anticoagulation proteins like protein C and protein S, that they are also vitamin K dependent. So when you give somebody warfarin, sometimes if they have a little bit low level of this protein C and S at the beginning, the drop in those proteins is much faster than the coagulation factor. So you will see a temporary hypercoagulable state. This causes warfarin necrosis in the area like symmetric, on the area that usually have high fatty, like a breast, like a stomach, you will see this one. Now if I say you, for example, this one has taken heparin a few days ago, what do you need the diagnosis? Heparin. Now we have heparin. Remember that these are both anticoagulants, right? So this is things that you have to remember that. What happens when you give the heparin to the people? Have you heard heparin-induced thrombocytopenia? Have you come across that one? No. Okay. So when you give, as I told you, warfarin, it's working on the vitamin K and it reduces the protein C. But heparin, what does? The heparin induces thrombocytopenia. It attaches to the platelet and causes platelet activation. So you will have clotting and thrombocytopenia at the same time. Usually you have, when you have thrombocytopenia, you expect bleeding, right? But here you have heparin and thrombocytopenia. This heat also is a very questionable subject. Okay. What is this? What do you see here? Anytime you look at the picture, anybody asking you what is this, you have to define the lesion.
I
know.
You will say yes. This is my job to remind you a million times. You have to define. So you will see you have some erythematus, papules, right?
Swelling in the
But they are erythematus or they are a little bit different.
They're not erythematus.
What are they?
They,
Purpuric.
yeah.
This is extravasation, right? They are purpura. You have purpuric, and then contrary, for example, to the chicken pox that you see the lesion on the upper part of the body, is mostly on the lower leg.
Also doing more.
Yes. So this is a vasculitis. It's a small vessel vasculitis. It's called leukocytoplastic vasculitis. This can have many reasons: infections, medications, and also sorry? Mosquito bite very rarely, but it can have antigen, it can cause develop. This one, you know, what is the mechanism of here? This pathogenesis here in the vasculitis?
Reaction to chemo.
Pathogenesis here, vasculitis. Which type of the hypersensitivity reaction? Oh, I should again do it from back of your mind out. So this is type 2, right? This is immune complex, right? And then when you have this immune complex on the skin, which other organ you need to think about whether it's involved or not?
Kidney.
Kidney, right? Anybody comes with the vasculitis, then you want to make sure that this kidney is involved or not. Have you heard the name Henoch? HS purpura, Henoch Cholinergic purpura? Not yet. Okay, so we will have here later. So just remember that is vasculitis that involves the joints and involves the GI tract. Okay, just want to make sure that you know the shape of the picture. What is this?
Psoriasis.
No, no.
What is this? See, people are not agree with you. What is this? Look carefully. What is this? Again, try to define. What is this? What is this?
Sunburn.
Right? This is the place of the clothing, right? So basically this is a photosensitive. This shows you that this reaction has something to do with light, right? Again, here you will see sharp edges have something to do with light. So when a photosensitizer comes and sits on the surface of the skin, we can have two types of the reaction. We can have phototoxic or we can have photoallergic. Exactly like in contact dermatitis. We said we have irritant contact dermatitis, that is the direct effect of the product on the skin, or we have allergic contact dermatitis that creates an allergic reaction. So here we have phototoxic and we have photoallergic. But the thing is that here, this distribution shows that this is somehow related to the light. And these are phototoxic reactions. This is like a acute sunburn reaction. They appear very quickly, and they exactly like the sunburn. Redness, swelling, sometimes residuation, and usually when they heal, they will heal with some sort of post-inflammatory hyperpigmentation. So from the medication, many chemicals or natural products can cause this phototoxic reaction. From medication-wise, for example, tetracycline group of the antibiotics, fluoroquinolone are the common one. And then one of these natural things is this furocomarines in some plants like a lime, like a celery, that can cause this reaction. We call this phytophotodermatitis. Means something with the plant and photodermatitis. Phytophotodermatitis. Sometimes the original reaction is not very obvious. So usually, for example, in the sunny climate like here, bartenders, the people who are handling these liquids and juices, with the contact with the light, just come with this pigmented patch on their hand. Sometimes the initial reaction may be not that obvious. So this is a phototoxic reaction. What are you doing here? Okay. And what is this? Here again you will see the exposed part, usually the V part of the neck is the exposed part, right? And but here you will
Plaque.
see
Plaque.
erythematous plaque, papules and plaque, and these are eczematous regions. So this is a photoallergic, right? For example, fragrances, some sort of medications, topicals, especially topical creams, topical antibiotics are very prone to develop this photoallergy.
This is different than a contact dermatitis.
Here you need the light.
Light.
Here you need the light. And the allergic contact dermatitis, you don't need the light. But the mechanism is the same. Type 4 hypersensitivity reaction, you need to develop an eczematous reaction. So you need to first sensitization. Then when the contact happens, the rash appears after 3-4 days, doesn't come immediately. And usually they can even spread to the area that is not contact because it's an allergic reaction, right? But in phototoxic, like erythema contact dermatitis, this is a direct effect of the chemicals on the skin. So it can, everybody can get that. It doesn't need sensitization, and the reaction is immediate. Okay, what is this? This is a malnourished alcoholic man.
Does this also have to do with the sun, or?
It has to do something to do with the sun as well, yes.
So more plaques.
Photosensitive reaction, especially on the neck and also upper part of the body. And you will see here the scaling is not like a scaling we have seen before, right? It's like a desquamation, like sheet of skin coming. It's not like, for example, you see on psoriasis. Can you see the difference, right? It's not the same. So what is this? Have you heard the name Pellagra?
No.
You haven't heard?
Pellagra?
No.
From you, yes.
Not from me. We
Otherwise,
have studies.
no.
It's a nutritional deficiency to niacin. And this is called causal necklace. This is again very questionable subject in the field of this disease because you have the niacin deficiency.
Niacin
Yes.
deficiency?
Yeah. The Pellagra has a period of 3D. It's called dermatitis, diarrhea, and demons. This is constitute the Pellagra. Dermatitis, diarrhea, and demons, and usually the dermatitis, the first sign that appears.
So the third D is?
Dementia. Diarrhea, dementia, and dermatitis. So, I think with this we come to the end of this today's session. Yep. So I provide my original presentation to this faculty, so they will give to you. And this presentation basically have lots of clinical information. Most probably you are not be able to use it right now, but keep it somewhere because when you go to the clinical, then there will be valuable information. It's not a comprehensive, but it's a good introduction. Any question about what we talked about today? Any question?
Can we do it again tomorrow?
Same or different?
Same style of teaching with different
Same
materials.
style. You know,
I like the
basically
The challenge.
the story goes like that because you should have some information, then we can work on that, right? Tomorrow's class will be likely at the next studies. We are going to talk about the acne, about the rosacea, about the hidradenitis suppurativa, and if we have time, we will go through some hair stuff, some nail stuff. If you have any any knowledge about that, you can go the same way. But if you don't know anything about anything, I put the picture here, then you will look at me and then say, you don't know, right? So you tell me I am ready for both of them, because in my mind, in my imagination, I tell that you don't know anything about dermatology, so I prepare that way. But then I realized that, for example, this Bullous disease and in drug reaction, I saw that on Friday you had some cases, you talk about that, I said, okay, they know something, so let's go this way. So for tomorrow again, choice is yours. I'm ready for both. If you going to study hard today, or you know some information about the acne and rosacea and this red face basically, so we go this way, or we go the classic way. Okay? Which one?
I'll let you know in the morning.
Okay. Great. That's okay. That's fine. That's okay. So, any question about the previous 1 week? Because tomorrow will be my last day here. So, any question from the what we talked during the past week? I try to make you familiar with the skin diseases. You are not frightened when you see. We try to categorize, and then we make different classifications of the different diseases and the prototype of that. So these are not comprehensive. You need to go more work on this, but this is a good introduction. At least you see what's important, what's not, how they look, how you describe, how to differentiate them. And then again, I will be by up to tomorrow afternoon here. So anytime, if you have any question, you can have a class together. You can, any of you can come separately. I'm fine with that. I'm okay. Okay? Thank you so much.
Thank you.
Thank you.
The only thing that happens today was the people who planned to come here and sleep a little bit, they didn't have the chance, right? No chance for
Who's been
sleep.
sleeping in your class, man?
No chance for sleep.
Are you gonna come upstairs to our small group thing?
Yes. I- Let me see your morning lab.
My morning.
Morning lab.
You
Morning
saw that,
lab.
didn't you?
You missed the morning lab.
You saw that, you saw that. I have witnesses.
He says everyone would be. Jan,
Yes.
how are you?
I'm
I
good.
missed you.
We're all the way over there now.
I know, right? Life sucks sometimes. And I do love my car.
Great bowl with vitamin K.
Yeah, she was on.
Yeah,
Well, he'd be pulling it out. I don't know from where.
listen, this is the only talent I have. When I was younger, I was in decathlon in elementary, like primary school, and my main focus was dictionary skills. So they would time us, like they would see how fast you could pull up information. So that's like the one thing I have focused.
So you pulled it up out of.
I pulled it when you started talking about warfarin.
Yeah.
I pulled up everything on it, and then I saw vitamin K, and I was like, okay, might as well say something. Yeah, no, that didn't come out of my head.
That's smart.
Thank you.
There's so many things right now floating around in my head that how.
Yeah, and then last
Is
night,
this
all
possible?
night, I was studying for the test.
Oh,
So it's just like, how can everything is just hitting me at once.
yeah. What test?
For Wednesday, the medication test.
Oh.